We start?
Yeah, we have a few folks joining us now. So to everybody for joining. We will wait for some people to arrive and get started. All right, Dr. Gonzalez, do you want to go ahead and start?
Okay. Well, thank you very much. It's a great pleasure to have all of you. My name is Enrique Gonzalez Mendez. I'm the chair of the Latino Health Forum, and I'm a clinical professor at the Sutter Family Medicine Residency affiliated with UCSF. I want to welcome all you to this 29 forum um, because I see we've been lucky to have every year these forums. And the theme this year is health inequalities and the evolution of the COVID response, the COVID-19 response. And of course, what we have learned is that and how we can heal is something that we've been learning. See, as many of you are aware, probably everybody, the COVID-19 has affected our county residents, specifically the Latino community and other marginalized communities. We have seen this virus impact crucial society pillars, leaving often the most vulnerable in our workforces at higher risk. The Latino Health Forum has always strived to inform professionals and community members about pertinent issues facing Latino and underrepresented populations to improve the access and quality of health services. In order to improve access and quality, we must address the ongoing disparities during this pandemic using the knowledge and resources from our own impacted communities. So we, with respect to social distancing and the need of efficiently and relay important information to our most vulnerable communities, we at the Latino Health Forum have decided to transition to our annual in-person event to a 6-day video series. Each session will be led by community leaders who are working to address this pandemic. We will hear from leaders in public health, mental health, community and nonprofit work, and much more. Our hope is that by creating an accessible platform to obtain information regarding the impacts of this pandemic, we will able to connect our communities to the necessary resources and quality health services they need to thrive during and beyond this pandemic. For more information, please join us, our mailing list, or follow our updates on our Facebook page. Also, questions regarding to our video series can be directed to latinohealthforum@gmail.com. Thank you, and thank you very much to our sponsors, and thank you very much to our speakers, of course, and the board that has been working so hard in order to be possible to be here with you. I want to tell you that today at 3 in KBBF 89.1 FM, you can listen the talks, and we are going to broadcast, unfortunately, different times every day after the Zoom, the electronic talk. Well, and honestly, it's a great pleasure to introduce our first speaker, Dr. Sundari Mays. Dr. Sundari Mays received her undergraduate degree from University of California, Berkeley, and her medical degree from University of California, San Francisco, UCSF, two of the most prestigious, amazing universities in the planet. I can tell you that. She completed her residency in internal medicine also at UCSF, and subsequently got a master's degree in public health with emphasis in epidemiology at UCB. She has been an assistant clinical professor at both Emory University, another great one, and University at UCSF. She's an expert in the field of tuberculosis, and she worked in that capacity with the World Health Organization and the Centers for Disease Control. Previously, she was a deputy health officer and TV controller for Santa Clara County. Dr. Mays joined Sonoma County as health officer in March 2020, just as the novel coronavirus pandemic began. And honestly, I have so much respect because that welcome was horrible. And she's been working so hard, and I thank you. After Dr. Mays, we are going to have a talk from Denia Candela, that is currently the Health Equity Officer of the County of Sonoma Department of Health, the Health Services, ensuring that equity is centered in the county's response to the COVID-19 public health emergency. In 2019, Denia founded her firm DC Equity Methods, focusing on training, development, and assessment of equity metrics and analysis. Very important nowadays. As a statistician, Denia leads with a unique approach to analytics by ensuring community narrative is at the forefront of metrics through a lens of equity methodology, and cultural competence with expertise that stems from lived experiences with disparities and community resilience. Denia has been involved in Sonoma County through her leadership with Sonoma County Los 100, Regional Parks Commission, and now First 5 Sonoma County. So please welcome these two amazing speakers. Dr. Mays, thank you for really to make the time, because I cannot imagine how busy has been all these months and your personal sacrifices. Thank you.
Thank you very much, Dr. Enrique Gonzalez Mendez, for this very nice introduction. And you're right, I joined this county as health officer right as this pandemic was starting. And it's been my pleasure to serve in this role. And I think in public health, we've made a big impact with help from all of our community partners and our hospitals, our federally qualified health centers, our community, most of all. So thank you so much for inviting me here to speak at the Latino Health Forum. Let me share my slides. Oops, just a second. Let me pull this up quickly. Okay, can you see my slides fairly well now? Let me just try to, oh, are you seeing my, sorry, something happened, 1 second, let me do that again. All right, is that okay? You're able to see?
Yeah, looks great.
Thank you so much. So what I'd like to do over the next 20, 25 minutes or so is to present on the following topics: social determinants of health. I think many people do know what social determinants of health are, but it's very important for us to understand them and to understand structural discrimination as a driver of health disparities specifically. And then to look at how COVID-19 has taken advantage of and widened these existing disparities. I'd also like to show some data and the local risk factors, especially in the Latinx community for COVID-19 transmission and health complications. Sorry. Then we'll look at the pandemic impacts overall and mental health, deaths, life expectancy, and then discuss considerations and what our needs are moving forward. So what are social determinants of health? This terminology is thrown around quite a bit, and people often think that it's only medical care that accounts for health outcomes that people face. But if you look at the literature, medical care only accounts for 10 to 20% of a person's health outcomes. All of the other social determinants of health, conditions such as where people live, what their income is, what kind of jobs they have, what kind of education background they have, food insecurity or food access to good food, community safety, and then of course the healthcare system itself and how people fit into the healthcare system. All these things really determine what a person's health outcomes could be. And it's kind of a way of looking at this is also that, you know, structural discrimination does drive health inequities. So newer models of social determinants of health have incorporated structural discrimination as a root cause of health inequities. What is structural discrimination? It includes racism, sexism, ableism, classism. And structural discrimination influences the laws and policies enacted that create inequities and the opportunities available to different groups of people. These broader laws and structures then influence the design of our public health and healthcare systems, neighborhood and built environments, education systems, and pathways to economic stability. All of these factors are interlinked and work together to impact one's health, well-being, and longevity. If you take a look at COVID-19 specifically and social determinants of health, the pandemic has just exacerbated the existing inequalities. These are the different areas we will be talking about: food security, housing, income and job security, social isolation, transportation, culture and language, access to healthcare, environment and safety. And we'll see how it is that COVID-19 has really displayed these inequities and worsened inequities that have already existed. So I'd like to spend a little time talking about social determinants of health in Sonoma County and look at disparities by race and ethnicity before and during COVID-19. And we're going to pick out a certain areas here in the social determinants of health to dive into a little deeper. Let's talk first about economic stability. And as I present these slides, I want to note that on the left, we're going to have Sonoma County data pre-COVID. And on the right, we're going to be looking at state level, California state level data to see what the pandemic impacts have been in these particular areas by race and ethnicity specifically. And we're comparing mainly the Latinx population to the white population at this time, white non-Hispanic population. So if you look at here in Sonoma County, economic stability in Sonoma County, prior to the pandemic, as you can see here, you take a look at Latinx residents, they're significantly more likely to live on or below the federal poverty level, that's FPL, than white residents that are non-Hispanic by a big margin. So that was existing social disparity. However, if you take a look at statewide data during the pandemic, on this side, Latinx residents were 3% more likely than white residents to report job loss during the pandemic, 4% more likely to have reduced hours or income during the pandemic, 5% more likely to having had to continue work as an essential worker, say in agriculture or healthcare, that kind of thing. And you can see here that white non-Hispanic individuals were much more likely to work from home than the Latinx community. So this is an example of how an existing pre-COVID inequity or disparity was just exacerbated in many ways by the pandemic. So now if we look at neighborhood and physical environment, you'll see here that if you take a look in Sonoma County prior to the COVID-19 pandemic, 34% of Latinx residents reported owning a home versus 69% of white non-Hispanic residents. And high costs of living often necessitate lower income individuals to share housing. And then there's multi-generational households and many people in one setting. And as we know, these kinds of conditions can lead to more transmission, especially in the setting of a pandemic with COVID-19. So local data just suggests here, if you take a look at household size and you look at the Black being Latinx, the green, white, non-Hispanic, that people who self-identify as Latinx are more likely to live with 3, 4, 5 persons in a household, whereas those who are white non-Hispanic are more likely to live in households of 1 or 2 persons. And then if you look at the pandemic impact by race and ethnicity, you'd see that Latinx individuals were twice as likely to have difficulty paying rent and mortgage due to the pandemic. So again, an example of how existing disparities and inequities were simply magnified by the pandemic. Looking at education access and quality of education, you can see in Sonoma County pre-pandemic here that a smaller proportion of Latinx students met or exceeded the grade level standards in English language arts than white non-Hispanic students, 36% as compared to 64%. And then disparities also existed in educational access and quality of education during the pandemic. You can see here that statewide data shows unequal access to technology to support distance learning by race and ethnicity, with a smaller proportion of Latinx students than other students having access to the needed technology for participating in distance learning. Now, once schools began opening for hybrid and in-person learning models last spring of 2021, a greater proportion of Latinx, 85%, versus white non-Hispanic families, 64%, opted to keep their students in distance learning, citing fears about COVID transmission. So not only were they more likely to keep their students in distance learning, they also had less access to technology to fully participate in distance learning. And you can see that this also translates into those with lower income having less access to technology than those with higher income, those with no bachelor's degree having less access to technology than those with having a bachelor's degree. And you can see that that public and private school mix, suggesting that kids in public school actually had more likelihood of being in distance learning than those in private schools. And we saw that here in our county as well, with private schools being able to open earlier in the pandemic to some in-person learning rather than just completely distance learning, just because they were able to, they had the resources to do so. Now let's look at food security and access to healthy options. In California, the survey data that I'm presenting here, you can see that 89% of white residents, that's looking at this graph right here, 89% of white non-Hispanic residents in Sonoma County reported they could always find fresh fruit and vegetables in the neighborhood prior to COVID. Whereas 59% of Latinx residents responded they could always find fresh food and vegetables. So this is the inequity that existed before COVID-19. But then if you look at during the pandemic, you can see that 11.8% in the statewide level data of Latinx residents had difficulty affording basic necessities due to the pandemic compared to 6.1% of white non-Hispanic residents. Again, an existing disparity that was exacerbated and worsened by the pandemic. And this is very important. I think Denia is going to talk a little bit in her presentation about how CURA and other community-based organizations have been instrumental in trying to bridge this gap and ensure that families that are needing can have access to healthy options and food security. So now let's talk some about community safety and social context. So pre-COVID, a similar percentage of Latinx and white non-Hispanic Sonoma County residents reported feeling safe in their neighborhoods, with slightly more white residents reporting feeling safe all the time rather than most of the time, so 59% to 53%. However, you can see that during the pandemic, similar proportions reported increasing household interpersonal conflicts and childcare difficulties. In fact, there was an increase in domestic violence and harm to children in families as a result of the pandemic, likely as a result of the stay-at-home shelter-in-place orders, as a result of the fact that more adults were working from home and not being out of the home, putting more pressure on the interpersonal relationships that occur within households. And you can see here so 14.3% of Latinx residents reported experienced an increase in the household interpersonal conflict as relates to 12.1% of white and non-Hispanic. So although this is happening in all race ethnic groups, again, disproportionately so in the Latinx population in the state level data. 1.8%, close to 2% of Latinx residents felt that they were treated unfairly because of race and ethnicity due to the pandemic, compared to 0.6% of white non-Hispanic residents. And close to 2% of Latinx residents experienced childcare difficulties due to the pandemic, compared to 1.7% of white non-Hispanic residents. Again, this is state level data. Another example of how some existing slight disparity led to an increase in disparity in the way people experienced a lack of community safety during the pandemic. Now, most importantly now, you can see healthcare access and quality, which is kind of what we're focusing on right now, or health outcomes. You can see that in Sonoma County, 16% prior to COVID, 16% of Latinx residents reported not having a usual place to go for medical care. And that's compared to 7% of white non-Hispanic residents. So this is before COVID. And you can see here that the pandemic greatly impacted some access to care as well. And part of it is people's preferences. So close to 30% of Latinx residents stated that they would not get the COVID-19 vaccine if offered, compared to 17% of white non-Hispanic. And this is due to so many underlying disparities. It could be language barriers or barriers in being able to appropriately, culturally represent what the benefits are of vaccination to a group that isn't English speaking, perhaps, and maybe doesn't view vaccination in the same way as other race ethnicities. But this is something that, again, through all of the work that Denia is going to describe, we've really been trying to outreach to groups in their own languages and try to get past these cultural barriers to improve our vaccination rates in the Latinx group. And I'm going to show you some data shortly here to show what we've been able to achieve. So 46% of Latinx had contacted a health professional about COVID-19 concerns, compared to 38% of white non-Hispanic. And about the same percentages of Latinx and white non-Hispanic residents statewide had ever been tested for COVID-19. But this is remarkable, and this is what we're trying to get through in order to get our Latinx and other communities vaccinated. And as we know, a vaccine has great benefit on health outcomes. So now I'm going to talk a little bit more about local epidemiology and risk factors for COVID-19 transmission and health complications. And I'm going to go a little bit faster. I wanted to really focus on those slides showing the disparities pre and after COVID. Now I'll go a little faster. This slide basically is telling us that essential workers are at greatest risk for COVID-19 exposure and household transmission. And it is really people working in agriculture and farm work, in construction and related trades, in food and beverage production, cleaning, janitorial, environmental services, in sanitation and public works. Those were the people that were impacted as a result of occupation being an exposure risk because they were essential workers who were out and about when other people were sheltering in place. We have seen workplace transmission by occupation, specifically in healthcare for obvious reasons. These are people who are treating and taking care of those people with COVID-19. Public safety, because we had some big outbreaks amongst our law and fire groups, our first responders, that is. Manufacturing, due to people being essential workers, caregivers and people who give personal care to others, food and beverage production, transportation, agriculture, etc., as you can see here. Household size has definitely been a risk factor for transmission. As I showed you from the Sonoma County data, those people in the Latinx community are much more likely to live in multi-generational households that include 4, 5, 6, or even more individuals. The mean household size in the Latinx group in California is 4.1 as compared to a mean household size of 2.5 in non-Hispanic populations. And as we know, this household size was associated with increase in transmission of COVID within the household. Case rates and trends, you can see the Latinx population has led throughout the pandemic, the case rate has been highest in the Latinx group. Even though Latinx population makes up only 27% of total Sonoma County's population, they've had a disproportionately high number of cases, specifically in that group, followed by Pacific Islander, American Indian, Alaska Native, Black, African American, Asian, multiracial, and then the white population, which makes up, I believe, somewhere around 63% of our population. And you can see that there is a disparity in the presence of underlying conditions. You look at the California Health Interview Survey, the same survey that much of the state data is from, between 2016 and 2017, you can see that obesity is much more likely in the Latinx population than the white non-Hispanic population. And this probably links in with food security and the availability of healthy options such as fruits and vegetables, rather than packaged products, or things, or fast food and that kind of thing. So diabetes, of course, linked to obesity, is higher in the Latinx group. Hypertension is slightly higher. Asthma is actually about the same, and heart disease about the same. But the obesity, diabetes, hypertension, all of which do lead to cardiac disease, you can see the disproportionality there. Latinx cases are occurring in younger age groups, simply because Latinx population tends to be younger in Sonoma County, but that's also the people who've been essential workers in the areas I showed you, the occupations where people did not shelter in place, and because there's a lower vaccination rate still in the younger Latinx population. As you can see here, the proportion vaccinated by age, it is our younger population that is less vaccinated. We did an excellent job in getting to our elderly population, and that's where the worst outcomes, such as hospitalization and death, were happening. And partly the reason for this is because these people had vaccine available to them later in the pandemic. It's really not until April that the younger age groups were eligible for vaccination. And as you know, the 12 and 15-year-olds have only been eligible for vaccine for the past several months. And if you look by race and ethnicity, still, the Black African-American non-Hispanic population is doing quite well, but these numbers are quite low in our county. I believe the Black African-American population only really makes up a few percentage of Sonoma County's population. As same with Asian. You can see that in the white non-Hispanic group, vaccination rates have been quite good. The Latinx group is catching up. There was a much greater disparity here. In the county, we have really put our efforts into reaching these populations: American Indian, Alaska Native, and the Hawaiian and Pacific Islander groups. Again, these are very small numbers of people, So small increases can vastly change these numbers. And those who describe themselves as multiracial, non-Hispanic actually are faring the worst in terms of vaccination. But you can see here that we're currently observing a 1.5 to 2% increase each week in the total number of Latinx residents fully vaccinated. And I attribute that to our health equity group and our outreach group and our vaccine group. And Denia is going to talk more about this. Again, I just want to note that the unvaccinated population is much more likely to get COVID, about 5 times more likely than the vaccinated population. But due to the huge number of increasing cases in the unvaccinated, we had an increase in the vaccinated population as well, since community transmission was extremely high with our second surge. Still, the unvaccinated population is about 4 to 5 times more likely to get COVID than the vaccinated. Unvaccinated persons were also hospitalized at a much higher rate compared to those fully vaccinated. This is actually a big difference, as you can see. So what is the benefit of vaccination, even if you get COVID-19? This is a question I'm asked all the time. The benefit is that you're much less likely to get sick with COVID, get hospitalized, and have really negative outcomes, such as death. So unvaccinated persons are 7 times more likely to be hospitalized, and up to 14 times more likely to be hospitalized at the surge of our Delta variant. Now you can see here that there's been a disproportionality in deaths as well amongst the Latinx. With the percentage of deaths, Latinx residents account for 27% of the population, as I noted, but roughly 42% of hospitalizations and 32% of deaths. And that is definitely a inequality and disparity. Asian, Black, African Americans, American Indian, Alaska Natives, and Pacific Islanders also are overrepresented in hospitalizations and deaths. And part of that is because of the lower vaccination rates in those groups. If you take a look here at COVID-19 deaths June 1st to present, you can see again that in the younger groups, the 25 to 44 and the 45 to 64-year-old groups, disproportionately Latinx populations have been affected. In the elderly population, 65 and over, we have had a lot more deaths in the white non-Hispanic population, and that's because we just have a much greater proportion of white non-Hispanic persons in that age group. So what about pandemic impacts on mental health, deaths, and life expectancy? As you can see here, the leading causes of death you can see here on the left, 2017 to 2019, and on the right here, 2020. And the most obvious difference is COVID-19 has now taken the 6th place in terms of conditions leading to death in 2020. And of course, that didn't exist 2017, 2019. And you can see here as well that there's been a slight difference in the ranking for influenza, pneumonia, Parkinson's disease, and kidney disease as compared to 2017-19 data when looking at 2020 data. There's another way to represent this data. As you can see here, the percentage change between 2017 to 19, 2020, that there's been 100% change for COVID-19 deaths, obviously, because they didn't exist in 2017 and 19. But you can see drug overdoses. This may be very surprising to some, 78.2% change in terms of the cause of death between the years 2017 to 19 and 2020. Kidney disease, chronic liver disease, all other causes are also up. Of note, influenza and pneumonia are down 21%. That may be because of the universal masking orders. So we saw a lot less influenza in 2020 than we did in the previous years. And if you could take a look at the excess deaths by underlying cause by race and ethnicity, you can see that in the Latinx group, there's a significantly greater than expected death in 2020 due to drug overdose, right here, 2.75. suicide, chronic lower respiratory disease, kidney disease, and unintentional injury. And we need to research this and find out what the reasons are, especially for the drug overdose, which has become a very big problem, as you know, nationally, here throughout the state and locally here in Sonoma County. So this was the only racial ethnic group that experienced a greater than expected number of suicide deaths. As you saw before in this slide, suicide was actually down 15% overall in 2020 compared to the previous years, 2017 and 19, but in the Latinx population, suicide was actually increased. And these are other things that we need to look into. So again, this is showing the excess deaths by drug overdose and really focusing on that. And as you can see here, there was a greater than expected increase for unintentional overdoses, more so than intentional overdoses were actually lower. And so this again is something that we need to seek an explanation for. Why is there such a greater than expected increase for unintentional overdoses? And in public health, we are now looking at all this data and working with our partners to try to understand better what the root causes for these disparities are, so that we can then address them. But of note, the increase in drug overdose deaths are much greater now for fentanyl and for opioids than heroin. So if you look at the light blue is 2017, the kind of mid-shade blue is 2018, dark blue 2019, and the kind of yellow is 2020. We've had a much greater increase in opiates and fentanyl in terms of cause for overdose. Again, looking into this, we're going to hopefully be able to find some of the root causes and how then we can address these issues as a county and as a state and hopefully as a nation.
Really quick, Dr. Mays, just cutting in to say we have a 2-minute time check.
Oh, thank you very much. I think I'm almost done. So in 2020, the life expectancy decreased 2.1 years for Latinx residents, but only 0.7 years for the white non-Hispanic residents. And you can see these other disparities. COVID-19 was responsible for 7% of all premature lives lost for Latinx, compared to 1% for white non-Hispanic. And COVID-19 contributed to 12% of total deaths for Latinx residents, compared to 3% for white non-Hispanic residents. So I'm actually going to end here. We all need to address this question. How can we respond as a community? And moving forward, as I just said, we need to address the root causes of health inequity in our community. And we need to really take on structural discrimination and unequal access to opportunities. And this has to be a community-driven, collaborative approach, really focusing on system change to address these issues. So these inequities, a take-home message, have existed all along, but COVID-19 has really laid them bare and worsened the disparity and inequity. So we really need to recognize the critical importance of all the social determinants of health to address COVID-19, but other health disparities, and to improve health outcomes overall for everyone. So let me just stop there. Sorry, I know that went on for a little longer, but I don't know if we have some time for Q&A.
Yes. Thank you so much, Dr. Mays, for that beautiful presentation. It's really great to, hear the facts and the numbers, so we know what a lot of the stuff that has been going on in our communities actually grounded in. So I appreciate that. We'll just quickly take a few questions. So for folks who want to ask a question, you can use the raise hand option and to ask a live question, or you can put it in the Q&A section at the bottom of your screen, and we can answer those. I do want to just start with a quick question. So earlier you mentioned that there was an increase in the vaccination rates among Latinx residents, and I'm wondering if you, based on that, I know it might be a little bit too early to tell, but have you seen a trend where there are less hospitalizations and deaths due to this increase of vaccination rates? Because I know you mentioned that the Latinx community did have a large amount of hospitalizations and deaths. So I wanted to see if that has been showing up in the numbers yet.
Yeah, we definitely are seeing a much decrease in hospitalizations and deaths in fully vaccinated persons. So if we look at every single group, what we're seeing is that, as I noted in the slide, a big disparity in who's getting hospitalized and who's having the negative outcomes. And largely it is unvaccinated individuals. 80% of those in the hospital are unvaccinated, and 80 to 100% of those in the ICU are unvaccinated. And the majority of deaths are still occurring in unvaccinated.
Wow. Wow. It's good to hear that information. Thank you so much. We're going to take a live question. So give me 1 sec here. So now, Noemi, I think, if you want to answer your.
Okay, hi. Basically, I was wondering if there's a way we can get a copy of your PowerPoint. I work for the government county also for Family, Youth, and Children's, aka CPS. And I think it'll be very helpful for our department to be able to have this information. I can share it with the rest of my building. Is there a way that we can get a copy, or how can we access that information?
I can probably quickly answer that. There we go. So yeah, thank you for that question. I know we will be adding the recordings for this video on our website and on our YouTube channel, which I mentioned before. So that would be a great way for you to be able to access the information that was offered on these slides. So thank you for the question. We'll go ahead and take some that have been submitted. So someone is asking if you know if the vaccine will be available for children 12 years of age soon. Do you have any knowledge on that?
Yeah, the vaccination is already available. Pfizer is available for kids 12 and older. What we're waiting for is approval for the 5 to 11-year-olds. And we think that's going to happen by end of October, early November.
Awesome. Great. That's some great news to hear. So hopefully people can start preparing for that. So we have somebody who is mentioning here the role of, the community health workers or promotoras in addressing SDOH. Not too sure what that is. I don't know if you're aware of that, but I'm maybe just talking about the work that the healthcare workers or promotoras are doing in your department, if you're aware of that work.
Yeah, I think, Denia, aren't you going to address some of this?
I'm going to talk a little bit about on our presentation, but I can say that promotora direct work and involvement has been critical in the avenues of our response. I think if anything, that's been what's helping us reassess and center their input, feedback, and just knowledge. So we currently, as a point of clarification, we have community health workers in the COVID-19 response, and we collaboratively work with other community-based organizations and might have networks within those.
Mm-hmm. Awesome. Great to hear. And, that kind of leads to this next question where, you talked about, the social determinants of health and how health is, honestly made out of these various parts. And wondering if you can maybe just speak a little bit about the different partnerships that the county might have with other orgs or the community that, seeks to address some of these. I know it might be helpful for folks to just be aware about, the work that's going on.
Yeah, actually, I think Denia is going to talk some of these collaborative approaches that we have with our community-based organizations, with our healthcare partners, with, many different organizations that we're working with. So I think that's going to be part of her presentation.
Awesome. And then just a last question right here that we'll take. If you do submit other questions, we will send them to Dr. Mace and maybe we can get them answered at a later time. But for now, the last question, someone's asking in regards to what you were talking about with the increased suicide rate in the Latinx community, if there will be, resources to further educate the community about what's going on and some of the drug abuse that might lead to the unintentional deaths that you were talking about earlier?
Yeah, absolutely. And that's something that we need to do a much deeper dive into. I found it really surprising that the unintentional overdose and that was actually quite high, but the suicides as well. So why is it that only in the Latinx group are we seeing an increase in suicide, where we've seen a decrease in other racial and ethnic groups? This is a question that needs to be addressed. So I agree. It's going to require to find out what the root cause is and go out and likely provide a lot more support, education, mental health services, reach out to ensure that people feel like they have options, that they have resources, if they're feeling desperate about whatever it is that they're experiencing. So I really think we've got to focus on that in public health.
Yeah, definitely. Well, thank you so much, Dr. Mays, for your presentation and letting us hear about, what the county has been working on and, what the facts are out there with regards to our specific, local area. So thank you so much. We will be now transitioning over to our next speaker, Denia Candela, who will be presenting on more what we're talking about, county efforts in relations to equity and what we are doing, on the ground, and we're in collaboration with other community partners. So thank you so much, and I'll hand it over to you, Denia.
Thank you, Pam. I'm going to share my screen, if that's okay. And as always, I hope that there's no technical difficulties on this end. Sounds like we can see my screen. Thumbs up. Yeah. Okay, perfect. A pleasure to be here. Thank you, Dr. Mays, for that presentation. And thank you, Pam and Latino Health Forum, for having me here today. To start off, as part of today's presentation, I'd like to really center us on really what our common definition of equity is that we have as a county that is credited to the Office of Equity, and we'll take it apart further into health equity. But this always helps us understand, to be on the same page as what is really equity, right? Equity is an outcome where we can tell the difference in critical markers of health, well-being, and wealth by race or ethnicity. And it's a process and where we actually explicitly value the voices and contributions of people of color, low income, and other underrepresented, underserved communities who identify then solutions to help us achieve that outcome. Let that simmer for a little bit there. It's a lot, but it's, I think, acknowledges the fact that it's a process and an outcome. It has to take. Health equity is when, so if equity is an outcome, then health equity, it's the outcome and where we have access to live in those healthy, everybody has a healthy and thriving life, regardless of socioeconomic status, ethnicity, gender, national origin, language spoken, and housing status. With that, we'll go, I wanted to talk a little bit just about what we're walking through today. And some of the tools that have supported our work in public health, particularly during COVID-19. Throughout this presentation, you'll find a series of tools and frameworks that acknowledge the systemic gaps that ultimately resulted in the disproportionalities that we have witnessed throughout COVID-19. Please keep in mind that the work is centered in ongoing revision of its system, and it is far from perfect. Yet it's to be grounded in the following points and its outcomes as we look into an upstream approach and as it relates to the social determinants of health and how that is all correlated. We'll look at race as a primary contributor of those inequities. We'll also look at the disproportionality in data, not to the extent that Dr. Mays presented, but we'll work on humanizing some of those numbers and why it's important to have narrative as part of and qualitative analysis. We'll also look into community wisdom and what does that mean? How do we actually engage in community and what have we learned at public health that could potentially be so helpful to you all as well. So this is what we called or what we looked at this upstream approach in how we have learned that COVID-19 has revealed inequities in the health and economic security of a lot of our communities. You can see right here on this end how our current public health practice will look at risk behaviors, disease injury, mortality rates, and the ideas and where we're starting to shift into what the emergency health practice could be from looking from an upstream approach where we look and embody all institution inequities, social inequities, living conditions, and the heart of it all is policy, right? So this, one of my favorite visuals to identify how they can be, how we look at the social determinants of health, how that we're all interconnected to all as well. So going to the next slide. With that said, here are some of our guiding principles for when we looked at COVID-19 and what we must take in consideration to make those conscious efforts. So I'm having trouble with my mouse here. There it is. So in the COVID-19 response, what we're working towards achieving is recentering the impacts of systemic structural racism and the association between these systems and really the health disparities that we have seen throughout the time in Black, Indigenous people of color. The use or epi-data or data-driven approaches to intentionally invest and allocate the right resources for those communities who are the most at risk. We'll talk a little bit later about fostering meaningful relationships, but that leads to leading culturally responsive approaches and communications with our community while reducing stigma, including that's associated with race, ethnicity, in our COVID-19 response vaccine, and also historical trauma. So let's talk a little bit about why race and health equity. Sometimes we're talking about health. Isn't it health equity? Shouldn't it be just race under racial equity? And we've looked at some of the approaches towards the social determinants of health and how it's interconnected towards the upstream approach. In this visual, we can see the importance to begin the journey of understanding those critical markers and how it truly begins beyond the binary privileged and unprivileged, right? And it intentionally centers the many ways in which someone may hold a piece of privilege. This is credited to the Canadian Research Institute and goes in hand with quantitative intersectional study on primary data collection for a Black feminist theory framework. It came back to the 1950s. That term was first credited to Kimberly and Crenshaw in 1989. I have to acknowledge the Black women and the wonderful work they have been doing. And it's a framework that assumes that an individual's experiences are not simply equal to the sum of their parts, but represent intersections of axes of social power. So right in the center, we can see, you guys might be familiar with the Sylvia Duckworth's Wheel of Privilege, but this is centers where power is right in the middle of the wheel. And as you come out, you'll start to see culture, merit status, racism, colonialism, and how it all interconnects to one another. I have another visual here in the next slide that talks more where we center race and health equity and how those critical markers of health, such as health education, like we talked about earlier, housing status, income, are all embedded into one's ability to achieve that healthy outcome. This is how complex our institutions and existing structures have developed to be inequitable by design and driving us to the harm of the communities that we have now seen suffer. All good to note is that we're moving to good things to note as we move into thinking into recovery for the next stages and resiliency, and how we can look at our own institutions, including ourselves as government, and how we can support Black, Indigenous people of color and the effects that they've been throughout the pandemic. This is the Public Health of Boston Institute, so something to think. We're revisiting this slide again because as Dr. Mays shared earlier, it shows our disproportionality of communities of color but actually sees from an epidemiological perspective what trends we have studied throughout Sonoma County. And I'll note here that we know that at the state level, we've been able to get a perspective on the same story that we're seeing here locally. Black, Latinx, and Pacific Islanders were carrying the disproportionate, or still carry disproportionate impact of COVID-19. Working age Black African were dying at 3 times the size of their population. Latinx Californians were making up 61% of those positive cases. 45% of deaths, and yet they comprise 39 of the population. In our Pacific Islander community, we're also dying at a rate of 2 times their population size. We know so many of these communities have disproportionate impact rate. In fact, essential workers were also highlighted as part of that, as you guys have seen through Dr. Mays' presentation. The numbers I just mentioned are part of that bar height framework, and it can be found on their website through the recovery and resilience, recovery and resiliency. There it is. Another piece that it's been incredibly important for us, in addition to the numbers, it's the community narrative. This is an input from different sources and only captures a small portion of the different stories that we know are so incredibly important to center our design processes, the reassessment of our existing systems, and the reassessment of our existing structures. I invite you all to think about how we can support healthy outcomes and in our ability to center the knowledge from an upstream approach as well. And I think if there's one thing we've learned from this effort is that when we allow community to lead and co-design systems, those systems will serve the people that are the most impacted, create venues for healing in a way that community feels respected and acknowledged. So these are like a snippet and a small glance of what that was looking like when we were looking after the response. We have been able to center community in some areas of our response. And one of the ways in which we've been able to center those voices, it's been part of the Latinx health work group, or what is now the health equity community group. In the health department, we had group members that with eyes and ears towards making sure we centered the experiences of Latinx, indigenous language people in our community. And equity design process included direct input for community and engages in meaningful conversations with its members and the communities that were impacted by these inequities. The membership have shifted, changed, and grown. They've informed the Department of Urgent Needs and support those who contract COVID-19 and their families, and develop target mitigation strategies to reduce further spread of the disease with the community, and also informed Department of Operational Best Practices. Their work led to the beginning of the CURA project, the health equity framework, and our ability to look at data through a disproportionality lens. Another space that we hold is the public health and promotoras pláticas, where we have direct conversations with our promotoras that have served as an informative space, yet breaks the siloed approach between community and government. So that it's in development. It started fairly not long. It didn't start long ago, but that is another space. And other partnerships that center to make better with folks like Collective that I believe that project. I'm sure anything a couple days later. Latino service providers, the COC. Those are.
Hi, Denia. I just want to cut in saying that we have a little trouble hearing you in your last bit. I don't know if you're near your mic and you want to adjust.
Of course. Is that better?
Much better.
Great. Just remarking the other partnerships that we've been able to have through, and they've been critical in terms of our response. Raíces Collective, the COC, Latino service providers, and the CURA project that I'm sure you guys, I believe they're going to be presenters as well of the forum. One of the ways in which we've been able to send really working on repairing and improving systems and where our community feels reflected. I want to leave you with some guiding principles that I've actually used in some training and how to work with communities who've seen firsthand the impacts and burnout of disaster work. This may be replicated at community-based organization level, other medical institutions, but I'll leave this for what it means to be meaningful, what it means to do meaningful engagement. And it recognizes that it can be deepened or broken more quickly in times of an emergency. It establishes recognition and acknowledges a government's role in historic and current roles that perpetuate those harm and inequities. It also centers transparency about what can be done and cannot do within the inside and outside roles. Communication, being a good listener, leaning in to being respectful of the different communication styles in different cultural contexts, and being, I feel like more communication you can never go wrong with that. Accountability is a huge one. It's something that we've heard time and time again from our community. Follow through and basically ensure that we are following up and saying that what you will do. And learning to commit, learning from mistakes and improving the systems that are in place. So I'll leave you all with that. And I think if I can pick one thing that we've learned throughout the response is, again, when we center voices of those who have been the most impacted and we make them part of the decision-making process, we are able then to address things from an institutional perspective and a structure perspective. And in doing so, we elevate them and acknowledge the impacts. So that's it for my piece of the presentation. I'll leave it up for questions and we can go from there.
Awesome. Thank you so much, Denia. Really, really appreciate that. And, it's not very often that we really get to hear what are the lenses that a lot of public health workers are working through. And so to be able to really understand that equity lens is really, really helpful for folks, especially people on our call, right? Who are usually concerned with equity, concerned with, justice and equality. And so thank you so much. I do want to see if we can just revisit some of the questions that were posed earlier about the partnerships that are sometimes available. So I'll repeat what we had. So like I said, before, we got a brief rundown on the social determinants of health. Health is made up of lots of moving parts, different parts that are structural. And I just want to know, can you speak a little bit more about those partnerships that you mentioned earlier with the health equity group and seeking to address disparities, and specifically like how that has differed from what the county has done in the past, right? And just the transitions and how you've seen that impact play out.
Yeah, of course. I think you bring an excellent point, Pam. So what used to be the Latinx Health Work Group was established within the Department of Health Services, to my understanding, the first of its kind, where it took folks who were directly boots on the ground, doing work directly, and brought them together to convene what is now the Health Equity Community Group. That got then further developed. There were many accomplishments with the project, including the development and the RFP for the CURA project. That's how the county kind of landed on that. It came the articulation from the needs that community would then develop within a county system. Then our language, it's RFPs, right, in government, right? So that's kind of what was, and that created the project itself. And now has evolved to include other members of our community, other people that are not specifically identified as Latinx and Indigenous, right, but others as well. And we have now a health equity community group. And I would say was definitely one of its kind and established by our previous director, and we have been able to keep that going. And we've developed additional spaces where we can hear directly what other perspectives are and other works with our Pacific Regional Islander Task Force, for example, right? And acknowledge that each community in Sonoma County, it's slightly different. And we're not a monolith, right? And different approaches work for different people. So it's a work in progress yet. I think we have that, and the public health pláticas with promotoras have been, I would say, a very a place where we can inform directly promotoras of what's going on, in addition to already leveraging other partners with the CURA project or the COC and the folks that are part of all of those different spaces. Yeah. So I'm mentioning a lot, but also recognizing that there's an overlap and we're not a monolith at the same time, right? So
yes, no, definitely. And I'm glad that that work is being done. And, for folks who are curious and want to know more about that, we will be having a workshop panel next Tuesday with a few folks from different organizations that will really speak more about their what you mentioned, on the ground efforts. So please join us for that. Another question I want to mention, which is a little bit of a mix of what Dr. Mace mentioned a little bit earlier and maybe your perspective on it. So Dr. Mace mentioned earlier that the vaccination gap was a little bit, bigger with Latinx residents, and over time we've seen that it has that gap has narrowed, specifically when looked against non-Hispanic white counterparts. And so I'm wondering if you think some of the efforts that you're talking about to reach the community have contributed to that closing of the vaccination gap. If so, how? What are those efforts?
Happy to take that on. Yeah. I think from our perspective, it's important to acknowledge that we've been growing together almost to an extent with some of our community-based organizations. The pandemic really revealed the existing safety nets that are in place. So when we're able to reach vaccination rates to those traditional safety nets, what else can we do to reach beyond those who are not part of those safety nets, who don't have a family resource centers to go to, who don't have a typical CBO to go to? So it's been, I think, an ongoing effort of learning together and how we can take it really an upstream approach, grassroots level approach, and really enable to reach those. They've been successful because we know that trusted messengers or promotoras and folks who are doing boots on the ground work are effective, they meaningfully engage, and we're able to get information. And there's been progress. So I'm incredibly proud of the work that we have been able to do thus far. And we also acknowledge that it's a time to revise what has worked in the past, what can improve, be better, and then what can we do in the future. So.
Yeah, definitely. I agree. And it's always great to strive towards that improvement, right? And to see where the other gaps that we might have not considered can be closed and addressed. So thank you so much. I will have another question. So earlier you started your presentation with this kind of like guiding principles for equity and the way you use equity. And I think it's still, I know it kind of gets, that word kind of gets thrown around a lot, especially with equality. And so I'm just wondering if you, working from the equity office, can just speak a little bit more to our audience to really clarify like the difference between like equity and equality and how your department kind of really looks at both of those.
Yeah, just as a point of clarification too, I do work for the Department of Health Services. Our department in the Office of Equity is an office established to work countywide. And you guys may already know Director De La Cruz, it's leading those efforts. I just wanted to clarify that.
Yeah,
I think
my apologies.
No, it's okay. I think our department, what we're trying to do is make sure that we have our own approaches embedded within our programs and our systems, right? In health equity. Oh boy, I think that is a really good question. Equality, you guys have ever seen the picture of like the boxes, right? And then for those of us who have been diving into equity and there might be, the word gets overused, right? We are like, well, what does justice feel like for some of our communities who've been disproportionately impacted? Because it really is embedded in institutionalized and structural racism, right? So I think that's where all of that, it's interconnected. And in health, we look at it and how all those existing structures and pieces to our systems then affect healthy outcomes for all communities in our populations in Sonoma County. So I would say that's a summary in how we look at it in health. Like we acknowledge the existing gaps that are within systems and the power wheel that I presented, right? And we then take that further to understand how that impacts healthy outcomes for communities here in Sonoma County. Dr. Mays, anything to add?
No, I think you really covered that. I mean, I don't have anything to add, just that, there's so much work to be done. And I don't know if our presentations really conveyed that. I presented a lot of data, and I'm sorry I didn't get to synthesize it more, because the problems have all been laid out. The solutions are what we need to spend a lot more time diving into. And it's a learning process for all of us, but it's been fantastic to have our own health equity officer within the COVID unit and a health equity group at the county level. And these are just things we can start on. A lot more discussion needs to happen.
No, yeah, definitely. And I think this is just a really great way to kick off this series because we are hearing, from from public health, just, what's been going on. And like you said, it sounds a little bit like just laying out the problems, which is important, right? We need to know what the beast looks like and before we go into battle, right? And so what it's really great about doing this series for the audience, if you're going to stay tuned for the rest of the presentations next week and tomorrow, we're going to have folks from these different areas and different community orgs come in and talk about what their approach to these solutions are. And so that's really important to know, right? There's not really one place with all the answers. We're all here, we're all in community, really working with each other and exchanging the knowledge that we have. So thank you so much to both of you. I really appreciate you taking your time to come speak with our community and share all your knowledge. So I really, really appreciate that. I will hand it over to Dr. Gonzalez, who will talk about what is to come and what folks can expect for a broadcast later on for through KBBF. So Dr. Gonzalez, I'll hand it over to you.
Thank you. Thank you very much, Dr. Mays, and really thank you for all the fantastic work that you've been doing. Sonoma County is an example, but that's thanks to your effort and your personal sacrifices, I know. And of course, your professional knowledge. And thank you, Denia, because what you're doing is amazing. And for years, we've been looking this kind of movement that now seems to be in motion. Thank you very much. And at 3, we'll broadcast your talk, and I'm sure many people are going to listen. Um, just tomorrow, we have Dr. Green is going to talk about the pandemic and the virus. So it's going to be at 12 Pacific time. Some people are not at the Pacific time, so just make your time for being there. Thank you very much. And I don't know what else telling you, but your job has been such an amazing, has changed many things. Someone that worked at the community for more than 30 years can tell you, I witnessed this change and this effort from the public health that Dr. Mays is the leader. Thank you, and see you tomorrow.
Yes, thank you, everyone. And just some last minute
Thank
notes
you.
that our videos are going to be available on our YouTube channel within 48 hours of the presentations. They'll also be made on our website. So please go ahead and visit our website. And for those of you tuned into Facebook, yes, we are doing a Facebook Live for some of these sessions. So thank you so much to everybody, and we'll see you all tomorrow. Thank you.
So